touch upon some of the new combinations or new regimens that are coming out. Some of this we've already talked about. We talked about ibrutinib and venetoclax. And, personally, I think this is very exciting data. There are different studies ongoing at different centers, many asking the same question about how deep a remission you can get, whether you need to keep people on a maintenance type approach. And so randomizing patients, there's some trials such as the Captivate trial, where patients are randomized after a year or so of therapy if they're MRD negative or not, whether they need to stay on therapies or not. So really important questions. There's also much more smaller studies, but looking at 3-drug regimens such as ibrutinib with obinutuzumab and venetoclax, or acalabrutinib with venetoclax and obinutuzumab. And personally, I don't know what my take on this is, that they show great efficacy, but way too early to know whether one of these is better than the next. And frankly, way too early to know whether you need all 3 drugs or not. I mean, I look at some of this data, you compare them to the phase 1 studies that were done with obinutuzumab and venetoclax. The MRD negativity rate, to me, with 3 drugs versus 2, comparing the same study done in the same population doesn't look that radically different to me. So I personally think we still have to wait and see whether that plays out, whether it's really worth doing all that, or whether it should be a sequential rather than a concurrent approach, and that's going to go on. And there's data. They're standing out with a new Pi3 Kinase Inhibitor, umbralisib, in combination with a CD20 ublituximab and venetoclax in refractory patient population. Very high efficacy. I know that they're interested in trying to develop this in the frontline setting as well. But again, exciting, important data, much better tolerated Pi3 kinase inhibitors than what we've seen in the past. But there's really going to be many more patients that need to be studied before we're going to know how to use that. Jan, I went through that pretty quickly due to limited time, but what do you any different take on those studies that I just mentioned?
Maybe just a brief discussion about the Pi3 kinase inhibitors, because we just didn't discuss them much, and at least for CLL, 2 of them are approved. And if we imagine we wouldn't have BTK inhibitors or venetoclax, then we would have probably talked a lot about the Pi3 kinase inhibitors. They are effective, and they've been around for a few years, and their use has just been discouraged by side effects that are, in comparison to the other agents, more concerning: autoimmune complications and infectious complications, which make them more difficult to give, and their efficacy seems to be somewhat lower when compared to the BTK inhibitors and venetoclax, but they are still a good alternative in selected patients. If they are intolerant, for example, to the BTK inhibitors, then I still sometimes use the Pi3 kinase inhibitors. And I'm very happy to hear that other Pi3 kinase inhibitors are being developed, because we are sometimes struggling with side effects and intolerance to the BTK inhibitors, and resistance to venetoclax. So there's still a need to keep the Pi3 kinase inhibitors in the field. They're currently not much used, but it's good to have that option. And if there's a better Pi3 kinase inhibitor, like the ones which you talked about, umbralisib, then that would be helpful to the field, I think, for selected patients. Maybe one last discussion, since you brought up these combination trials. I think the role of minimal residual disease is very controversial, because many of these combination trials, they aim for getting many patients into MRD negative remissions. But I think what we've also learned is that ibrutinib really gets patients into very long remissions, and patients have very good survival and best survival with the BTK inhibitors, which are agents which don't get patients into MRD negative remissions. So what we are traditionally coming from is this belief that only MRD negative remissions are good remissions, and only patients who have very deep remissions are doing very well. The BTK inhibitors taught us a different story, and therefore I think the role of MRD testing and the necessity to get patients into MRD negative remission, that's right now quite controversial.
Well, appreciate that. I want to close by just mentioning two other therapies that are out there. So zanubrutinib, of course, approved for mantle cell lymphoma, not yet approved for CLL. It has, some of the same properties that we talked about with acalabrutinib, perhaps a cleaner side effect, adverse event profile, but we really need to, we'll need to see sort of comparative data. There is a randomized trial going against ibrutinib, and that'll be important to know. And finally, CAR T cells we saw this year in mantle cell lymphoma, not CLL, but in mantle cell lymphoma, really encouraging data. CAR T cells, some of the earliest publications were in CLL, and then it was lost for a number of years and really not done. I think mostly because of these other therapies are so successful, it's hard to know who you would want to put at risk. I think, though, there's also other problems about the fitness of T cells in patients with CLL. What's the right patient population? Not too early, not too late. But I think more to come in CAR T cells in CLL. That's certainly, there's trials out there now ongoing trying to investigate this again after a long hiatus.
Yeah, I agree. I think with CAR T cells, we have to stay tuned as these treatments are being improved, as safety is increased. The Seattle group just recently published a small series from the Fred Hutch in patients who are ibrutinib resistant, where they combined CAR T cell therapy still with ibrutinib, even though patients didn't respond that well to ibrutinib anymore, but it had a beneficial effect on the side effects on the cytokine release syndrome. So I think many groups are still investing into CAR T cell therapy to improve it, to make it safer to reduce cytokine release syndrome, and hopefully also to achieve more durable remission with the CAR T cell products. It's right now something that's still experimental, but I think we're going to hear more about that.
This has been extremely informative. Thank you, Dr. Berger, for this insightful discussion. And thank you to our audience for watching Targeted Oncology presentation on precision medicine. We hope you found this discussion to be useful and informative.